Welcome back, everyone. In this lecture, we will discuss multiple topics in cardiology, starting with cardiac biomarkers, which plays a pivotal role in diagnosing myocardial injury and heart failure, and then continue with ambulatory electrocardiographic monitoring, which allows us to detect intermittent cardiac rhythm abnormalities that may not be captured on a standard 12-lead ECG, and so on. Now, let us begin with the cardiac biomarkers. Cardiac biomarkers are substances released into the bloodstream when myocardial injury occurs. They provide both diagnostic and prognostic information, particularly in patients presenting with acute coronary syndromes and heart failure. Selecting the appropriate biomarkers and understanding its time course are fundamental in clinical decision-making. The most important biomarkers today are cardiac troponin 1 and troponin T. Troponins are highly specific indicators of myocardial injury. After an acute myocardial infarction, they generally peak between 12 and 24 hours and remain elevated for up to 2 weeks. Because of this prolonged elevation, troponins are extremely useful for confirming myocardial infarction even when patients present several days after symptom onset. However, remember that an elevated troponin does not automatically mean myocardial infarction. Many other conditions can produce elevated troponin levels. These include congestive heart failure, atrial fibrillation, acute pulmonary embolism, aortic dissection, myocarditis, pericarditis, endocarditis, cardiac defibrillation, myocardial trauma, infiltrative cardiomyopathies, ischemic stroke, intracranial hemorrhage, severe hypotension, chronic kidney diseases, sepsis, hypovolemia, acute respiratory distress syndrome, chronic hypertension, diabetes mellitus, hypothyroidism, and rhabdomyolysis. Therefore, troponin results must always be interpreted together with the patient's symptoms, ECG findings, and overall clinical presentation. Another important biomarker is creatinine kinase, MB or CK-MB. CK-MB typically reaches its peak approximately 1 day after myocardial infarction and returns to normal within about 3 days. Although it has largely been replaced by troponins for the initial diagnosis of myocardial infarction, CK-MB remains clinically valuable because a new rise after normalization can indicate reinfarction, making it useful when evaluating recurrent chest pain shortly after an initial infarction. Like troponin, CK-MB may also be elevated in myocarditis, pericarditis, muscular dystrophy, cardiac defibrillation, and chronic renal insufficiency, limiting its specificity. It is also important to appreciate that the timing of troponin measurements depends on the assay being used. Modern high-sensitivity troponin 1 and troponin T assays can detect myocardial injury significantly earlier than conventional assays, allowing earlier diagnosis and more rapid clinical decision-making in emergency settings. Several other biomarkers may also be encountered. CK-MB, AST, and lactate dehydrogenase, or LDH, may increase following myocardial infarction, but they have relatively low specificity and are therefore no longer preferred as primary diagnostic tests. For patients with the suspected heart failure, attention shifts to B-type natriuretic peptide, or BNP, and N-terminal pro-BNP, or NT-proBNP. These peptides are released by the ventricles in response to increased ventricular volume and elevated end diastolic pressure, reflecting myocardial wall stress. Elevated BNP supports the diagnosis of the heart failure, but it is important to recognize that increased BNP levels may also occur in atrial fibrillation, pulmonary embolism, and pulmonary hypertension. Consequently, BNP should always be interpreted within the clinical context. Now, examine the accompanying graph illustrating cardiac enzyme kinetics after myocardial infarction. Notice how high sensitivity troponin rises earliest. Conventional troponin remains elevated for the longest duration, and CK-MB rises and falls much earlier. This characteristic pattern explains why troponin is ideal for diagnosing myocardial infarction, whereas CK-MB is particularly useful for identifying reinfarction. Ambulatory ECG. Now let's move to ambulatory electrocardiography, an indispensable tool for evaluating intermittent cardiac rhythm disturbances. Unlike the standard ECG, which records only a few seconds of cardiac electrical activity, ambulatory ECG continuously records 2 or 3 ECG leads over an extended period, allowing physicians to capture transient arrhythmias and correlate electrical abnormalities with patient symptoms. The choice of monitoring device depends largely on how frequently the patient's symptoms occur. If symptoms occur daily, the preferred investigation is a 24 or 48-hour continuous ECG, commonly known as Holter monitor. If symptoms occur weekly or monthly, longer monitoring is required. In patients, clinicians usually select prolonged continuous monitoring lasting 1 to 2 weeks or an even monitor, increasing the likelihood of recording the responsible arrhythmia. The first monitoring option is the continuous ambulatory monitor. This device is a small, lightweight, battery-powered recorder available either as a wearable box or an adhesive patch. It continuously records 2 or 3 channels of ECG data. Many devices include patient-activated event markers, allowing patients to indicate exactly when symptoms occur, making interpretation more accurate. These monitors are generally worn for 24 to 72 hours, although some systems allow continuous monitoring for up to 14 days. For patients with very infrequent, unexplained symptoms, a different approach is required. An implantable loop recorder, or ILR, is a small subcutaneous monitoring device designed specifically for long-term arrhythmia detection. The device is typically implanted in the left pectoral region beneath the skin. It continuously monitors the heart rhythm and stores recording either automatically, according to pre-programmed criteria, or manually, when activated using an external magnet. Because implantable loop recorders can remain functional for months to years, they are particularly valuable in patients with unexplained syncope, cryptogenic stroke, or infrequent arrhythmias. It is also worth remembering that implanted cardiac devices, including pacemakers for bradyarrhythmias and implantable cardioverter defibrillators for tachyarrhythmias, continuously monitor cardiac rhythm and possess sophisticated algorithm capable of automatically detecting and storing significant arrhythmias. Another commonly used option is external event monitor. One type is the most event monitoring device, which is placed on the patient's chest after symptoms begin and records the cardiac rhythm in real time. usually for approximately 30 to 150 seconds. Another type is the event or loop recorder, which continuously records ECG data but permanently saves only the period surrounding a patient's triggered event. Typically, when the patient experiences symptoms and presses the event button, approximately 30 to 60 seconds of ECG recording are preserved for later analysis. More advanced systems include the auto-triggered event recorder. Rather than relying solely on patient's activation, these devices use a built-in algorithm to automatically detect, capture, and store asymptomatic arrhythmias, improving diagnostic yields in patients who may not notice every abnormal rhythm. Recent technological advances have also introduced patient-administered single-lead ECG devices. These commercially available systems use finger or wrist electrodes, allowing patients to record their own ECGs outside the hospital. Examples include the Apple Watch and Cardiomobile, which have become increasingly valuable for detecting intermittent atrial fibrillation and other rhythm disturbances. Finally, let's consider the clinical indications for ambulatory ECG monitoring. Its primary role is the evaluation of cardiac rhythm abnormalities, particularly when symptoms such as palpitations, dizziness, or syncope are intermittent and need to be correlated with the ECG findings. In addition, ambulatory ECG monitoring is widely used to assess pacemaker performances, elevated implantable cardiodefibrillator function, detect episodes of myocardial ischemia, identify late potentials, and assess heart rate variability, all of which contribute important information regarding cardiac electrical stability and overall cardiovascular risk. Now let's begin with the transthoracic echocardiography, commonly known as TTE. This is the most frequent performed echocardiographic examination. It is a non-invasive ultrasound study performed by placing a transducer on patient's chest wall. Ultrasound waves penetrate the thoracic structures and produce real-time moving images of the heart without exposing the patients to ionizing radiation. TTE is usually the first-line imaging modality whenever a structural heart disease is suspected. One of its primary indications is the elevation of normal cardiac anatomy and function. Using TTE, we can accurately assess chamber size, including enlargement of the atria or ventricles, ventricular wall thickness, which is important when diagnosing hypertrophy, regional and global wall motion abnormalities that may indicate myocardial ischemia or infarction, valve morphology and function, the morphology of the proximal greater vessels, and left ventricular ejection fraction or LVEF, which remains one of the most important measures of the systolic function. Beyond anatomical assessment, TTE plays an essential role in evaluating patients with clinical cardiac abnormalities. For example, it is indicated in patients presenting with chest pain associated with hemodynamic instability, because it can rapidly identify complications such as severe ventricular dysfunction, tamponade, or mechanical complications of myocardial infarction. It is also useful in patients with peripheral edema accompanied by an elevated jugular venous pressure, helping determine whether heart failure or another structural abnormality is responsible. Similarly, patients with new detected heart murmurs, unexplained hypotension, or syncope when a structural cardiac cause is suspected should undergo transthoracic echocardiography. TTE is equally valuable when evaluating suspected cardiac diseases such as aortic dissection, congenital heart disease, left ventricular thrombose, acute myocardial infarction with mechanical complications, pericardial effusions, and the cardiac tamponade. Because it is rapid, safe, portable, and repeatable, transthoracic echocardiography has become one of the cornerstones of cardiovascular diagnosis. Transesophageal echocardiography, or TEE. We now move to the transesophageal echocardiography, commonly referred to as TEE. Unlike transthoracic imaging, TEE uses an ultrasound probe that is passed into the esophagus. Because the esophagus lies immediately behind the heart, especially the left atrium, the probe is positioned very close to the cardiac structure. This eliminates interference from the chest wall, ribs, lungs, and obesity, producing images with significant higher resolution. TEE provides particularly excellent visualization of posterior cardiac structures, including the left atrium, the mitral valve, the aortic valve, and the interatrial septal. TEE becomes the preferred imaging technique whenever transthoracic echocardiography is technically inadequate or when exceptionally detailed visualization is required. It may even serve as the initial diagnostic test in certain life-threatening situations such as suspected aortic dissection, particularly when CT angiography cannot be performed because of renal failure or other contraindications. Another major indication is the detailed evaluation of valvular morphology and function. TEE is especially valuable when assessing valvular stenosis, valvular regurgitation, prosthetic valve function, and infective endocarditis, where vegetations may be missed on transthoracic imaging. Because of its superior spatial resolution, TEE is the preferred investigation for detecting infective vegetations and valve complications. TEE also evaluates several important cardiac diseases, including aortic dissection, complex aortic atheromas, intracardiac thrombi, cardiac tumors, and intracardiac shunts. One particularly important indication involves patients with atrial fibrillation or atrial flutter. Before electrical cardioversion or catheter ablation, TEE is performed to exclude left atrial or left atrial appendage thrombose. Since cardioversion is the presence of thrombose could precipitate systemic embolization or stroke. Although TEE is generally very safe, it is still an invasive procedure. Serious complications are extremely uncommon, occurring in fewer than 1 in 5,000 procedures. Potential complications include esophageal perforation, gastrointestinal bleeding, pharyngeal hematoma. Fortunately, with proper patient selection and experienced operators, these complications remain exceedingly rare. Now, let's discuss stress echocardiography. Stress echocardiography combines ultrasound imaging with either exercise or pharmacogenic stress to evaluate cardiac function under conditions of increased myocardial workload. Exercise stress is typically achieved using a treadmill or bicycle ergometer. When patients cannot exercise adequately because of physical limitations, pharmacologic agents such as dobutamine or adenosine are administered to stimulate physiological stress. Stress echocardiography is especially useful when standard stress testing produces inconclusive or equivocal results, or when the ECG alone is non-diagnostic. It is recommended in patients with an intermediate pretest probability of coronary artery disease who have a normal equivocal exercise ECG. Following acute coronary syndrome, stress echocardiography can help determine myocardial viability, thereby guiding decisions regarding coronary revascularization. Stress echocardiography also helps determine the clinical significance of valvular heart disease, including aortic stenosis, mitral stenosis, mitral regurgitation, and aortic regurgitation. Additionally, it is useful in evaluating patients with left ventricular systolic dysfunction of uncertain cause, latent or established pulmonary hypertension, left ventricular outflow tract obstruction in hypertrophic cardiomyopathy, and syncope of unclear etiology. For patients unable to exercise, dobutamine stress echocardiography provides similar diagnostic information. Low-dose dobutamine studies are particularly valuable for assessing myocardial viabilities, identifying dysfunctional myocardium that remains alive and may recover after revascularization. They are also useful in evaluating aortic stenosis associated with reduced left ventricular systolic function, helping distinguish true severe stenosis from pseudo-severe diseases. Like all stress tests, stress echocardiography has contraindications. Absolute contraindications are essentially those that also prohibits the exercise testing. Dobutamine stress echocardiography should not be performed in patients with significant tachyarrhythmias or severe systemic hypertension, as pharmacologic stimulation may worsen these conditions. Relative contraindications applicable to both exercise and dobutamine stress testing include abdominal aortic aneurysm, significant electrolyte abnormalities, left main coronary artery disease, and moderate stenotic valvular heart disease. Careful patient selection is therefore essential before performing stress echocardiography. Contrast echocardiography with agitated saline. Now let's discuss contrast echocardiography using agitated saline, commonly known as the bubble study. This technique enhances visualization of intracardiac blood flow and provides real-time assessment of cardiac shunts. The contrast agents used is agitated saline, which contains numerous tiny microbubbles of air. After intravenous injection, these microbubbles travel to the right side of the heart, where they are easily visualized on echocardiography. The primary clinical applications is the detection of the right to left intracardiac shunts. Most commonly, a patent foramen ovale or PFO, as well as intrapulmonary shunts. Understanding the normal physiology is very important. In a healthy individual without a shunt, the injected microbubbles remain confined to the right atrium and right ventricle. They then travel through the pulmonary circulation, where the pulmonary capillary bed filters and dissolves the bubbles before they can reach the left side of the heart. Therefore, The appearance of microbubbles in the left atrium or left ventricle shortly after injection strongly suggests the presence of an abnormal right-to-left communication, providing valuable diagnostic information that guides further management. This simple, inexpensive, and highly informative technique has become an essential component of the modern echocardiographic evaluation, particularly in patients with cryptogenic stroke, suspected pattern for foramen ovale, or unexplained hypoxemia. Now let's continue our discussion with contrast echocardiography using agitated saline, commonly known as the bubble study. This is, as I mentioned before, a simple, inexpensive, and highly valuable echocardiographic technique that provides important information about intracardiac and extracardiac shunts. Agitated saline is created by mixing normal saline with a small amount of air between two syringes connected by a three-way stopcock. This produces tiny microbubbles that are injected intravenously. These microbubbles are too large to pass through the normal pulmonary capillary circulation. So, under normal physiological conditions, they appear only in the right atrium and right ventricle before disappearing in the lungs. High-yield indications. The most important indication is the detection of right-to-left shunt. If microbubbles appear in the left atrium or left ventricle, this indicates that blood has bypassed the pulmonary circulation through either an intracardiac shunt, such as patent foramen ovale or atrial septal defect, or an extracardiac shunt, such as pulmonary arteriovenous malformation. Timing, sorry for that. Timing is extremely important during interpretation. Appearance of bubbles in the left heart within the first 3 cardiac cycles suggests an intracardiac shunt. Delayed appearance, usually after 3 to 5 cardiac cycles, suggests an intrapulmonary shunt. Another important application involves Doppler enhancement. Agitated saline increases the intensity of Doppler signals across the tricuspid valve. By improving Doppler quality, clinicians can more accurately measure tricuspid regurgitation velocity, allowing estimation of right ventricular systolic pressure, which is an essential non-invasive method for evaluating pulmonary hypertension. A third specialized indication is the diagnosis of a persistent left superior vena cava. If contrast is injected into the left arm vein and the coronary sinus opacifies before the right atrium, this is highly suggestive of persistent left supravena cava, an important congenital venous anomaly that may affect central venous catheter placement, pacemaker implantation, and cardiac surgery. Now let's discuss transpulmonary contrast agents, which differ significantly from agitated saline. Unlike saline bubbles, these newer ultrasound contrast agents, such as Definity, contains a stable microbubble that are small enough to traverse the pulmonary circulation. After intravenous injection, these microbubbles enter the left-sided cardiac chambers, producing excellent opacification of the left ventricle. The first major advantage is improved visualization of the left ventricular echocardial borders. Remember, this becomes especially valuable in patients with technically difficult echocardiograms, including those with obesity, chronic obstructive pulmonary disease, or poor acoustic windows. Improved border definition allows much more accurate calculation of the left ventricular ejection fraction, or LVEF. The second important use is improved assessment of regional wall motion abnormalities, making the detection of ischemic myocardium more reliable during stress echocardiography. The third application is identifying intracardiac masses, particularly left ventricular thrombose, which may otherwise be difficult to distinguish from normal trabeculations. Risks. Fortunately, serious complications are extremely uncommon. Remember that large clinical studies have shown that non-fatal myocardial infarction and death are exceedingly rare following administration of ultrasound contrast agents. However, mild adverse reactions may occur, including back pain, headache, urticaria, and rarely anaphylaxis. Clinicians should also exercise caution in patients with significant intracardiac shunts, where passage of contrast into the systemic circulation may occur. Now, we move to one of the most frequent tested topics in cardiology: exercise stress testing. Exercise stress testing evaluates how the cardiovascular system responds to increasing physical workload. Patients exercise on either a treadmill or a bicycle ergometer while continuous ECG monitoring and the periodic blood pressure measurements are obtained. The purpose is to identify inducible myocardial ischemia, exercise-induced arrhythmias, symptoms provoked by exertion, and overall function capacity. Risk stratifications. Exercise stress testing classifies patients into three prognostic groups. Low risk. Low risk patients generally require medical therapy alone without invasive investigation. Intermediate risk. Intermediate risk patients often require additional imaging studies such as stress echocardiography, myocardial perfusion imaging, or coronary angiography. High risk. High risk patients should undergo cardiac catheterization for definitive coronary evaluation. Always remember the three categories: low risk, medical therapy; intermediate risk, additional imaging; high risk, cardiac catheterization. Indications. Exercise stress testing is most useful in patients with an intermediate pre-test probability, approximately 10% to 90% of obstructive coronary artery disease. Remember that stress testing performs best in patients with intermediate probability, not very low or very high probability. Certain baseline ECG abnormalities limit interpretation of ST segment changes. Examples include left bundle branch block, digoxin effect, and estrogen therapy. Although ST segment becomes less reliable in these situations, exercise testing still provides valuable prognostic information. Beyond ECG findings, clinicians evaluate symptoms, total exercise duration, maximum heart rate achieved, blood pressure response, and exercise-induced arrhythmias. Remember that exercise capacity itself is one of the the strongest predictors of the long-term survival. False positive and false negative results occur, so results must always be interpreted alongside the patient's symptoms and overall clinical probabilities. Absolute contraindications. Exercise stress testing should never be performed in patients with acute myocardial infarction within 2 days, unstable angina, uncontrolled symptomatic arrhythmias causing hemodynamic compromise, symptomatic severe valvular stenosis, uncontrolled symptomatic heart failure, active endocarditis, acute myocarditis, acute pericarditis, acute aortic dissection, acute pulmonary or systemic embolism, and any acute non-cardiac illness that would worsen with exercise. For examinations, remember that acute unstable conditions, acute MI, unstable angina, acute myocarditis, acute pericarditis, acute endocarditis, acute aortic dissection, acute pulmonary embolism, these are absolute contraindications. When should the test be terminated? The exercise test should be stopped immediately if any of the following occurs. Target heart rate is achieved. The patient requests to stop. A drop systolic blood pressure greater than 10 millimeters of mercury despite increasing workload, accompanied by evidence of ischemia. Moderate to severe angina. ST segment elevation greater than 1 millimeter in leads without diagnostic Q waves, except V1 and AVR. Progressive neurologic symptoms such as dizziness, ataxia, or near syncope. Evidence of poor perfusion, including cyanosis or pallor. Technical failure or ECG or blood pressure monitoring. And sustained ventricular tachycardia. The examination commonly tests these termination criteria: falling systolic blood pressure, ST elevation, sustained ventricular tachycardia, severe angina, and neurological symptoms. Risks. Exercise stress test is generally very safe when properly supervised. Potential complications include myocardial infarction, cardiac death, arrhythmias, hemodynamic instability, and orthopedic injuries. The risk of serious complications is less than 1 in 5,000 to 10,000 supervised exercise stress tests, emphasizing that it is very safe diagnostic procedure when appropriate patient selection and monitoring are used. Bubble study, this is the examination pearl. So if you want to prepare for the examination, you should remember these points. Bubble study. Left-sided bubbles indicate a right to left shunt. Coronary sinus opacifies before the right atrium after left arm injection. Think persistent left superior vena cava. Definity and similar transpulmonary agents best for assessing LVEF, wall motion abnormalities, and left ventricular thrombosis. Exercise stress tests. Best for intermediate risk patients with suspected coronary artery disease. Low risk, medical therapy. Intermediate risk, additional imaging. High risk, cardiac catheterization. Never perform exercise stress tests in acute unstable cardiac conditions. Know the major termination criteria, especially hypotension, ST elevation, severe angina, neurological symptoms, and sustained ventricular tachycardia. Nuclear cardiology. Let's begin with the nuclear cardiology, one of the most valuable functional imaging modalities for evaluating coronary artery disease. The most commonly performed nuclear cardiac study is myocardial perfusion imaging, or MPI, using ECG gated single photon emission computed tomography, commonly known as SPECT. During this procedure, a small amount of radio-labeled tracer is injected intravenously. The tracer is taken up by healthy myocardial cells in proportion to blood flow, allowing us to visualize myocardial perfusion. The addition of ECG gating enables simultaneous assessment of left ventricular function, including ventricular wall motion and ejection fraction. Therefore, a single study provides information about myocardial perfusion, ventricular function, and myocardial viability. One of the major strengths of myocardial perfusion imaging is its ability to determine whether this functional myocardium is still viable. This distinction is clinically important because a viable myocardium may recover function after coronary revascularization, whereas a scar tissue will not. Another important application is the detection of myocardial ischemia. Areas that receive inadequate blood flow during stress, but normal blood flow at rest indicates reversible ischemia, while the defects presents during both stress and rest usually represents myocardial infarction or permanent scar. An additional advantage of nuclear cardiology is its strong prognostic value. Myocardial perfusion imaging predicts the likelihood of future cardiac events independently of the patient's symptoms, physical examination findings, resting ECG, and even exercise ECG results. Consequently, it is widely used for risk stratification in patients with suspected or known coronary artery disease. You will frequently hear myocardial perfusion imaging referred to as MIBI scan. This name originates from the commonly used technetium-based tracer, or SystemIBI. Stress testing may be achieved in two different ways. Whenever possible, patients perform treadmill exercise, which is considered physiologically superior because it reproduces natural cardiovascular stress. However, many patients cannot exercise adequately because of arthritis, peripheral vascular disease, neurological impairments, or poor function capacity. In such situations, pharmacologic stress agents are used. These include dipyridamole, adenosine, and regadenoson, all of which produces coronary vasodilation and stimulate the physiological effects of exercise by increasing blood flow to normal coronary arteries. Images are obtained immediately after the stress phase and then repeated approximately 3 to 4 hours later at rest. Comparing these two image sets allows identification of reversible ischemia and permanent infarction. The principal radiotracer includes thallium-201, which behaves as a potassium analog and is useful for viability assessment, and technetium-99m labeled tracer, including SystemIBI, Cardiolite, HexameBI, and MyoView, which provides superior image quality and are the most commonly used agents today. Indications for myocardial perfusion. Now let's discuss when myocardial perfusion imaging should be ordered. One important indication is the evaluation of patients with possible acute coronary syndrome who have a non-diagnostic ECG and negative cardiac biomarkers. In these patients, myocardial perfusion imaging helps determine whether clinically significant ischemia is present despite inconclusive initial testing. Exercise myocardial perfusion imaging is particularly valuable when the resting ECG cannot be interpreted reliably. Classic examples include patients with left bundle branch block or significant baseline ECG abnormalities that make exercise ECG interpretation impossible. It is also indicated in patients with an intermediate pretest probability of coronary artery disease when the exercise ECG result is normal or equivocal. In these situations, perfusion imaging improves diagnostic accuracy and assists clinical decision making. Patients with previous myocardial perfusion imaging whose symptoms have changed may require repeat imaging to determine whether ischemia has progressed. Ultimately, one of the principal goals of myocardial perfusion imaging is the diagnosis and localization of myocardial ischemia. When exercise is not feasible, dipyridamole or adenosine myocardial perfusion imaging is performed instead. Exercise testing remains the preferred options whenever possible because it provides additional information regarding exercise capacity, symptoms, blood pressure response, and arrhythmias. Pharmacologic stress testing is reserved for patients who cannot exercise or for those who are unable or unwilling to discontinue medications such as beta blockers or calcium channel blockers, which may interfere with exercise stress testing. Importantly, the clinical indications for pharmacologic myocardial perfusion imaging are essentially the same as those for exercise myocardial perfusion imaging. Contraindications and risks. Although pharmacologic stress testing is generally safe, certain contraindications must always be remembered. Coronary vasodilators such as adenosine, regadenoson, and dipyridamole should not be administered to patients with significant hypotension, sick sinus syndrome, or high-grade atrioventricular block unless a functioning permanent pacemaker is present. These drugs are also contraindicated in patients with reactive airway disease, including severe asthma, because they may precipitate bronchospasm. Pregnancy represents another important contraindication because of fetal exposure to ionizing radiation. The principal risk associated with the nuclear cardiology is radiation exposure, although the radiation dose is relatively low and generally considered safe. The examination should be performed only when the anticipated diagnostic benefit outweighs the potential risk. Stress echocardiography reminds us that stress echocardiography is another important method for evaluating inducible ischemia. Unlike nuclear imaging, stress echocardiography detects ischemia by identifying new regional wall motion abnormalities during stress rather than by evaluating myocardial perfusion directly. We will study these modalities separately under the echocardiography chapter. Cardiac catheterization and angiography. We now move to the cardiac catheterization, beginning with the right heart catheterization, also called pulmonary artery catheterization or the Swan-Ganz catheter. Unlike non-invasive imaging studies, right heart catheterization provides direct hemodynamic measurements, making it invaluable in critically ill patients with shock, pulmonary hypertension, or complex cardiac disease. The catheter is introduced through a large central vein and advanced sequentially through the right atrium, right ventricle, pulmonary artery, and finally into a distal pulmonary artery branch where the balloon is inflated to obtain the pulmonary capillary wedge pressure. As the catheter advances, pressures are measured continuously within each cardiac chamber. Consequently, right heart catheterization provides direct measurements of central venous pressure, right atrial pressure, right ventricular pressure, pulmonary artery pressure, and pulmonary capillary wedge pressure. Beyond pressure measurements, the Swan-Ganz catheter allows calculation of several important hemodynamic variables, including cardiac output, systemic vascular resistance, pulmonary vascular resistance, mixed venous oxygen saturation, oxygen delivery, and oxygen consumption. These measurements provide a comprehensive assessment of cardiovascular performance and tissue oxygenation in critically ill patients. An important calculated parameter is the cardiac index, abbreviated CI. Cardiac index is simply cardiac output adjusted for the body surface area, allowing comparison between individuals of different sizes. The normal cardiac index ranges from 2.6 to 4.2 liters per minute per square meter. Values below 1.8 liters per minute per square meter generally indicate severe impairment of cardiac function and are commonly associated with cardiogenic shock. One of the most clinically important measurements is the pulmonary capillary wedge pressure, or PCWP. This pressure is obtained by advancing the balloon-tipped catheter into a small branch of the pulmonary artery until blood flow is temporarily occluded. Under normal circumstances, the pressure measured beyond the occlusion reflects pulmonary venous pressure, and in the absence of pulmonary venous disease, closely estimates left atrial pressure. Therefore, pulmonary capillary wedge pressure serves as an indirect measurement of left-sided filling pressure and is extremely useful in evaluating heart failure and differentiating cardiogenic from non-cardiogenic pulmonary edema. Indications for the right heart catheterizations. Right heart catheterization is indicated in patients with shock when the underlying volume status or hemodynamic profile remains uncertain. It is also invaluable in patients with severe cardiogenic shock, particularly when acute valvular disease or cardiac tamponade is suspected. Another major indication is evaluation of patients with suspected or established pulmonary arterial hypertension, where direct pulmonary artery pressure measurements remain the diagnostic gold standard. Patients with complex structural heart disease, including congenital heart disease, left-to-right shunts, severe valvular disease, or significant pulmonary hypertension, often undergo right heart catheterization before corrective surgery to define the underlying hemodynamic abnormalities and assess surgical planning. Contraindications. Now let's consider the contraindications. Right heart catheterization should not be performed through a site with local infections because catheter insertion may introduce microorganisms into bloodstream. The presence of the right ventricular assist device represents another contraindication because catheter manipulation may interfere with the device function. Insertion is also contraindicated during cardiopulmonary bypass, where normal pulmonary circulation is interrupted and meaningful measurements cannot be obtained. Throughout your examinations, remember that distinction between these two investigations: nuclear cardiology evaluates myocardial perfusion, viability, ischemia, and prognosis non-invasively, whereas right heart catheterization directly measures intracardiac pressure and hemodynamics, making it indispensable in the assessment of shock, pulmonary hypertension, and advanced cardiovascular diseases. I should remind you that Swan-Ganz catheterization and pulmonary artery catheterization both are the same procedures with two names. Risk of Swan-Ganz or pulmonary artery catheterization. Although Swan-Ganz catheterization is generally considered safe when performed by experienced operators, it is still an invasive procedure and carries several important risks. The overall complications rate for diagnostic catheterization is less than 1%, making it relatively safe. Nevertheless, every operator must recognize potential complications. One of the most frequent problems in atrial or ventricular arrhythmias occurring in approximately 3% of patients. These arrhythmias develop because the catheter mechanically irritates the myocardium as it passes through the right atrium and right ventricle. Most are transient, but sustained ventricular arrhythmias require immediate attention. Another complication is catheter misplacement or kinking, which can prevent accurate pressure measurements or damage surrounding structures. Rare but life-threatening complications include perforation of cardiac chamber, rupture of cardiac valve, or pulmonary artery rupture. Pulmonary artery rupture is particularly feared because it may result in catastrophic pulmonary hemorrhage with high mortality. Additional complications include pulmonary infarction caused by prolonged balloon inflation, thromboembolic events, infections, and misinterpretation of hemodynamic data due to improper catheter position or technical errors. Within the first 24 hours after catheterization, serious adverse events such as death, myocardial infarction, or a stroke occur in approximately 0.2 to 0.3% of patients. Remember that ventricular arrhythmias during catheter passage through the right ventricle are the most common procedural complications and are frequently tested in examinations. Swan-Ganz catheter placement. This illustration demonstrates the stepwise advancement of a Swan-Ganz catheter through the right side of the heart into the pulmonary circulation. At the left side of the figure, notice the catheter itself. It contains several specialized ports. Right atrial port for measuring right atrial pressure, pulmonary artery port for pulmonary artery pressure measurement, thermistor port used during thermodilution cardiac output calculations, inflation port which inflates the small balloon located at the catheter tip. Now observe this sequence of catheter advancement. Stage 1, right atrium. The catheter is introduced through a central vein and enters the right atrium. At this stage, the monitor records the right atrial pressure waveform, representing central venous pressure. Normal right atrial pressure is low because the right atrium receives systemic venous return. Stage 2, right ventricle. The catheter advances through the tricuspid valve into the right ventricle. The pressure tracing changes dramatically. The right ventricle develops high systolic pressure during contraction but maintains very low diastolic pressure because it ejects blood into the low resistance pulmonary circulation. This is the stage where the ventricular ectopic beats or transient ventricular tachycardia may occur because the catheter touches the ventricular endocardium. Stage 3, pulmonary artery. The catheter passes through the pulmonary valve into the pulmonary artery. Here, both systolic and diastolic pressures increase. Unlike the right ventricle, the pulmonary artery maintains a measurable diastolic pressure, allowing distinction between these two locations on pressure tracings. Stage 4, pulmonary artery wedge position. Finally, the balloon is inflated. The inflated balloon wedges with a small branch of the pulmonary artery, temporarily blocking forward blood flow. This allows measurement of pulmonary capillary wedge pressure, or PCWP. Although measured within the pulmonary circulation, PCWP closely reflects the left atrial pressure, left ventricular filling pressure, and left ventricular end diastolic pressure in the absence of mitral valve disease. Remember that pulmonary capillary wedge pressure is one of the most important measurements in critical care. It helps distinguish cardiogenic shock from non-cardiogenic shock, cardiogenic pulmonary edema for ARDS, volume overload from hypovolemia, and left ventricular failure from right ventricular failure. This concept is tested repeatedly in cardiology and intensive care examinations. Left heart catheterization. Unlike Swan-Ganz catheterization, which evaluates the right heart, left heart catheterization assesses the left ventricle, aortic valve, coronary artery, and systemic circulation. The catheter is inserted through the radial artery, brachial artery, or femoral artery. It is advanced retrogradely through the aorta, across the aortic valve, and into the left ventricle. This procedure records left ventricular systolic and end diastolic pressure. Contrast may then be injected directly into the left ventricle during left ventriculography, allowing visualization of left ventricular size, regional wall motion abnormalities, left ventricular ejection fraction, and ventricular aneurysms. It is also valuable for evaluating mitral and aortic valve disease as well as myocardial disease. Remember that arterial access sites, radial artery preferred due to lower bleeding risks, femoral artery, and brachial artery. Indications for the left heart catheterization. The primary indication is assessment of coronary artery disease. It determines extent of coronary artery obstruction, severity of ischemic disease, and left ventricular function. It also evaluates patients with aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, and cardiomyopathies. The procedure confirms findings obtained from the echocardiography or non-invasive stress testing. Another important indication is evaluation of patients with a chest pain of uncertain origin, especially when non-invasive investigations are inconclusive. Remember that cardiac catheterization remains the gold standard for defining coronary anatomy. Contraindications. Although there are few absolute contraindications, several conditions should be corrected before proceeding whenever possible. These include severe uncontrolled hypertension, ventricular arrhythmias, acute stroke, severe anemia, active gastrointestinal bleeding, contrast allergy, acute renal failure, decompensated heart failure, active infection, severe electrolyte abnormalities such as hyperkalemia, and severe coagulopathy. Patients should be stabilized before undergoing elective catheterization. Risk of left heart catheterization. Major complications, including death, myocardial infarction, and stroke, occur in fewer than 3 per 1,000 procedures. Minor complications such as access site bleeding, hematoma, pseudoaneurysm, kidney dysfunction from contrast occur in less than 1% of patients. Incomplete or Non-diagnostic studies occur in fewer than 1% of cases. High-yield topics here is that right atrium or central pressure 1 to 8 meters of mercury reflects right ventricular preload or overload intravascular volume status. Right ventricle 1 to 8 millimeters of mercury diastolic pressure is 15 to 30 millimeters of mercury systolic, characterized by low diastolic pressure with moderate systolic pressure. Pulmonary artery is 4 to 12 millimeters of mercury diastolic and 15 to 30 millimeters of systolic. Similar systolic pressure to the right ventricle, but with a higher diastolic pressure because the pulmonary valve has been crossed. Left atrium, pulmonary capillary wedge pressure, PCWP, is 4 to 12 millimeters of mercury. Best indirect measurement of left atrial pressure and left ventricular filling pressure. Left ventricular end diastolic pressure, or LVEDP, is 4 to 12 millimeters of mercury, reflects the left ventricular preload and compliance. A high-yield examination pearl. Right atrial pressure is equal to central venous pressure, or CVP. Pulmonary capillary wedge pressure estimates left atrial pressure. PCWP rises in left-sided heart failure and pulmonary edema. The major difference between right ventricular and pulmonary artery pressure tracings is the pulmonary arteries' higher diastolic pressure. Normal PCWP and LVEDP are both approximately 4 to 12 millimeters of mercury and are frequently tested in MCCQE and cardiology examinations. Coronary angiography. Coronary angiography is considered the gold standard for visualizing the coronary arteries. It involves the injection of radio-opaque contrast media directly into the coronary ostia through the cardiac catheter. This allows direct visualization of coronary lumen and identifies the location and severity of coronary artery stenosis. Coronary angiography, this is a higher definition. Coronary angiography is the gold standard for localizing and quantifying coronary artery disease, or CAD. Indications for coronary angiography. First, coronary angiography is performed to define coronary anatomy and determine the degree of luminal narrowing. Second, it identifies the presence and extent of obstructive coronary artery disease. Third, it helps determine whether the patient would benefit from revascularization, either by percutaneous coronary intervention, or PCI, or coronary artery bypass grafting, or CABG. Finally, it is indicated when the diagnosis, or CAD, remains uncertain despite non-invasive testing. For the MCCQE, remember that think of coronary angiography where the result will change management, particularly before PCR or CABG. AHA 2011 recommended indications, high yield box. This box contains several exam favorites. Coronary angiography is recommended in patients with disabling chronic stable angina despite optimal medical therapy, high-risk findings on stress testing, serious ventricular arrhythmias or heart failure, persistent diagnostic uncertainty after non-invasive investigations, and patients who cannot undergo non-invasive testing. High-yield example. If a patient has high-risk ischemia on stress testing, coronary angiography is usually the next diagnostic step. Contraindications. The major contraindication is severe renal failure because iodinated contrast may worsen kidney function. Always evaluate renal function before administering contrast. Remember to assess serum creatinine, estimated GFR, history of contrast allergy. These are the important points. Complications and risks. Diagnostic coronary angiography is generally safe. Major complications, including death, myocardial infarction, or stroke, occur in less than 3 per 1,000 procedures. Minor complications, including vascular access problems and contrast-induced nephropathy, occur in less than 1%. The most commonly tested complication is contrast-induced nephropathy, especially in diabetic patients and those with chronic kidney diseases. Coronary angiography schematic, it's a very high point. This figure demonstrates the major coronary arteries and their branches. The left main coronary artery divides into left anterior descending, or LAD. The LAD supplies anterior wall, anterior septum, and the apex. Important branches include septal perforators and diagonal branches. LAD occlusion causes the classic anterior stenosis, often called the widowmaker. Left circumflex artery. The circumflex artery travels in the atrioventricular groove and gives rise to obtuse marginal branch, OM1, OM2, and OM3. It supplies the lateral wall, posterolateral myocardium. Lateral wall myocardial infarction is commonly due to circumflex occlusion. Right coronary artery, or the RCA, supplies right ventricle, inferior wall, is a node in most individuals, AV node in most individuals. Important branches include acute marginal artery, posterior interventricular artery or posterior descending artery, and posterolateral branches. RCA occlusion typically produces an inferior myocardial infarction, often accompanied by bradycardia due to AV nodal ischemia. Left panel of the figure. Sorry for that. The left diagram shows angiographic segmentation of the left ventricle into inferobasal, inferoapical, apical, anteroapical, and anterobasal. These segments are used when interpreting ventriculography and regional wall motion abnormalities. Know which coronary artery supplies each myocardial segment. Hemodynamically significant stenosis. One of the most important examination facts is a stenosis becomes hemodynamically significant when the luminal diameter is narrowed by 70% or more. If there is a more than 70% coronary stenosis, it is a significant obstruction. This number is frequently tested. Diagnostic catheterization. Beyond angiography, cardiac catheterization can assess complex physiological abnormalities. Different pharmacologic agents help unmask disease. Examples include fluid loading for latent constrictive pericarditis, afterload reduction, or inotropic stimulation to increase the left ventricular outflow tract gradient in hypertrophic cardiomyopathy, acetylcholine or methylogenovin or to provoke coronary vasospasm, pulmonary vasodilators such as oxygen, calcium channel blockers, adenosine, nitric oxide, or prostacyclin to assess pulmonary hypertension. Remember that acetylcholine provocation testing is used to diagnose vasospastic or transmittal angina. Now let's move to the contrast-enhanced CT coronary angiography or CCTA. This is a non-invasive alternative using ECG-gated multi-detector CT scanning. It produces high-resolution images of the coronary arteries without catheterization. Indications. CT coronary angiography is used for evaluating coronary artery stenosis, assessing bypass graft patency, and investigating patients with low to intermediate probability of CAD. Diagnostic accuracy. Sensitivity approximately 85% and specificity approximately 90% for detecting obstructive CAD greater than 50% stenosis. Remember that CT coronary angiography has a high negative predictive value, making it excellent for ruling out coronary artery disease in low to intermediate risk patients. Contraindications. Avoid CT coronary angiography in patients with contrast allergy, severe renal dysfunction, and significant tachycardia or irregular heart rhythms, which reduces image quality. Risks. Potential complications include radiation exposure and contrast-induced nephropathy. High yield. The high yield point here is that unlike invasive angiography, CT coronary angiography is diagnostic only. It cannot perform PCI. Magnetic resonance imaging or cardiac MRI. Cardiac MRI provides outstanding soft tissue contrast and excellent spatial resolution. Unlike CT, it does not expose patients to ionizing radiation. Gadolinium contrast is frequently used to identify myocardial scar and tissue fibrosis. Indications. Cardiac MRI is valuable for evaluating congenital heart disease, aortic abnormalities, myocardial viability, and cardiomyopathies. Importantly, it is considered the most accurate method for measuring ventricular ejection fraction, particularly right ventricular function. High yield points for MCCQE. Gold standard for myocardial tissue characterization. Best tests for myocardial viability and scar assessment using lead gadolinium enhancement. Most accurate modality for right ventricular ejection fraction and no ionizing radiation. Cardiac MRI uses a powerful magnetic field, making it contraindicated in patients with certain metallic foreign bodies or implants, including some pacemakers, implantable cardio defibrillators or ICDs, cardiac resynchronization therapy or CRT devices, cerebral aneurysm, clips, metallic shrapnel, and body piercing that are not MRI compatible, allowing confirm the implanted devices are MRI safe before proceeding. Another important contraindication is severe kidney dysfunction when gadolinium contrast is required. In patients with advanced renal impairments, gadolinium may increase the risk of nephrogenic systemic fibrosis, making careful patient selection is essential. Finally, Remember that the main risk of cardiac MRI is the interaction between the magnetic field and metallic devices, which can lead to device malfunction, heating, or movement, posing a significant safety hazard. Thank you for attending this lecture. If you like my lecture or other contents of my channel, don't forget to like and subscribe, share, and press the bell icon. Have a nice day.